from the American Academy of Pediatrics.
In children younger than 3, as many as 20% of fractures caused by abuse are initially misdiagnosed.
A new report from the AAP looks at evaluating young children with fractures for child abuse.
A child shows up that has a fracture and you're trying to figure it out. I treat the family just the same as anybody else. I try to be respectful to them. I'm honest with them. And I try to make it very clear that I'm trying to do the best thing for this patient.
Plus, a new study examines the impact invalid vaccine doses have on young children.
What I hope that our research does is just help alert pediatricians that invalid doses can occur. And we also want people to know that there are tools available that can help.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Malinky. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about evaluating fractures for signs of child abuse. David, you know I work in a NICU where we take care of infants who are discharged to home, and some of the toughest cases we get called to consult on are when there's been suspected head trauma in a baby.
Ooh, I can imagine. And knowing what the cause of this trauma is can be difficult. Babies just have big heads, so they fall on their heads, and that might be the first thing to hit the ground.
That's right. It's not easy. And of course, we worry about brain injury, but assessing for skull fracture can be really complicated. Do we do x-rays, get CT scans?
And it's not just with head injury that we have to question how we work up a fracture, especially in children who are not yet talking. I always worry that a fracture in a young child might not be from an accident.
So today, it is no accident that we have someone here to talk with us about evaluating young children with fracture for child abuse. Joining us is one of the authors on a new clinical report, Dr. Suzanne Haney, and she joined us back on episode 109 when we talked about child abuse prevention.
Dr. Haney is currently the only board-certified child abuse pediatrician in the state of Nebraska. She is a professor of pediatrics at the University of Nebraska Medical Center College of Medicine. Dr. Haney, welcome to the show.
Thank you so much for having me.
Thank you for joining us. You helped write the report, Evaluating Young Children with Fractures for Child Abuse clinical report, specifically about fracture in child abuse. How common are fractures from child abuse versus from unintentional injuries?
So unintentional injuries are very common. We know kids love to run and fall and jump and hurt themselves, etc. In young children, so toddlers and infants, about 20% of the broken bones that we see are probably due to child abuse.
That seems pretty high. And when you're taking a history about a child's fracture, what questions are really important to make sure you ask?
Just like with any history, I just want to know the details about how the fall happened, how the child landed, and then obviously more details on family history, social history, etc. is very helpful.
And when you're getting that family history, social history, are there conditions where a child might just be more susceptible to fracture, and how do we rule those out?
So there are conditions. Some of them are the ones that we only see on the board exam, like Menkes, but others we actually do see more commonly, like osteogenesis imperfecta, or something that you would know, Joanna, that the children who leave the NICU after having been horribly ill and then have a metabolic bone disease as a result of not being able to get the nutrition that they needed. So we do see those. Getting a history of the child having been in the NICU for many months, or a family history where a lot of kids have broken bones, or sometimes we see it on exam where children have features that are more consistent with osteogenesis imperfecta, like blue sclera, or their bones themselves that look abnormal. They're bowed, they're very pale. So those are the things that we're going to be looking for in those cases.
And what about rickets? Is a deficiency in vitamin D a common fracture culprit?
It's actually very rare, especially in our society here where most children are able to get an adequate amount of vitamin D. We do look for it. We do frequently measure vitamin D levels, but it is incredibly rare for us to see that as a cause of a child breaking a bone.
That is good to know. Now, when we're born, we have about 300 bones, but of course, some of them merge together. And so as we get older, we're left with about 200 individual bones. That's still a lot of things that can break. Are there certain fracture sites in children that make you more worried for abuse?
Yes, there are some that we consider very specific for abuse. Those are particularly rib fractures, multiple fractures, metaphyseal, or we call them CMLs or CMFs, classic metaphyseal fractures. A lot of physicians know of them as chip fractures or bucket handle fractures that occur at the very end of long bones. Those are the ones that are much more specific for abuse and have us very concerned.
And when you suspect a fracture, I think most pediatricians would get an x-ray. Is that the only radiologic study necessary for diagnosis?
Not usually, especially in young children. When we're talking those under 2 and especially infants, we will get a skeletal survey, which is a series of usually around 24 or more images of the different bones. And then in infants under 6 months or so, we will also want to get a head CT to make sure we're not missing a head injury too.
A diagnosis of child abuse can be so emotionally charged. When we're contemplating this diagnosis, is it important to get laboratory studies to back it up? And are there any that we should have at the top of our minds?
Yes, like I mentioned before, we're going to be looking at vitamin D levels. We're going to be looking, obviously for other things, calcium. So we usually do a complete chemistry panel, and then making sure that we're not missing other injuries. So the chemistry panel is also going to give us liver enzymes, pancreatic sufficiency testing. So we'll give us an idea of other things that are going on.
And David had just mentioned how emotional these diagnoses can be. I've seen a bias where I practice in the state of Pennsylvania, with Black families being much more likely to be suspected of abuse than white families. How do we as pediatricians remain objective and mindful of this disparity when we're concerned about child abuse?
Well, I think what your question is actually the first step, is recognizing that the bias is there and taking a look at how we're making a diagnosis. There are some really nice algorithms. Pittsburgh has some nice ones to help us, clinical decision rule, to say, outside of the social aspects, I have this fracture, I have this history. Are these consistent? Are they not? And that way it helps to work the bias out of it.
And can pediatricians make the diagnosis of child abuse from fractures alone? And if we have questions, is there anyone we can call for help?
So yes to the first question, and you can make the diagnosis. You have multiple fractures in a child that's non-ambulatory, that doesn't have a history that's consistent. You're really going to be heading that way toward abuse. And then myself and my colleagues are always available. Many institutions have a child abuse pediatrician. We call them Gen Caps, a general pediatrician who has a special interest in child abuse. So there should be somebody in most institutions, especially our academic medical centers, that is able to be there and to help you. And even in our area, Nebraska has some incredibly rural, more than half of our state is farm. And so we're actually here in Omaha available as a center for anyone in our region to call. So there should be somebody that you should be able to reach out to.
Dr. Haney, when someone does call you for help, I imagine they're looking for real-world advice. Pretend I'm that pediatrician and tell me how you approach these cases of suspected abuse.
Yes. So in these cases, I usually try to think through it as I would any other patient. So a child shows up that has a fracture and you're trying to figure it out. I treat the family just the same as anybody else. I try to be respectful to them. I'm honest with them. And I try to make it very clear that I'm trying to do the best thing for this patient. So that's kind of the mindset I have when I start. And then it really is, again, gathering all of the information. I am not going to make a decision until I'm at the end. And so I'm getting the information about the injury. I'm very, very thoughtfully trying to make sure that I'm dotting all my I's and crossing all my T's. And then at the end, when we get to the point where it's like, okay, I've got all of my information. I have the x-rays and I have all the studies. And now I'm there to say, I really think this is abuse. So that's when I have to sit down with the family and honestly tell them, this is what I have to do next. I'm concerned somebody has hurt your child and I need to call the authorities. And I usually say it in just about that way. I'm not blaming and is certainly not going to place blame on anybody or accuse. That is not my role. And I would say that should be across the board with all of us as physicians. We are not accusing people. We are there to make sure children are safe and healthy. And that usually ends up being pretty good. And it's not infrequent. Well, I have a family that'll say, thank you for finally being honest, because I think everybody else has been thinking that and they haven't treated me very nicely.
And have you had a family where they've gone down this path of an abuse diagnosis and it's been found to not be true?
Yes, I've had a few cases where I have, one in particular was referred in from an outside hospital with multiple fractures. And when I evaluated the child, it was very clear that the bones were not normal. They were very osteoporotic on x-ray, and it ended up being that the child had osteogenesis imperfecta. And it's hard to tell a family that your child has this chronic medical condition, but it was also very nice to tell the family that I had just gotten off the phone with the investigators and the child was going home with them. So that was really neat.
And do you have any thoughts for pediatricians about reestablishing trust in those kinds of encounters?
It's hard, especially if somebody else has lost that trust. I think the thing that I can do the most is to be respectful and honest and say, this is what happened. This is what I know. And the one thing I'm not going to do is I'm not going to lie to you.
That's so good to know. And Suzanne, before we let you go, do you have any last takeaways for pediatricians who want to make sure they get this diagnosis right?
I would say be on the alert, recognize that fractures can occur as a result of abuse. Read my clinical report. That should help guide people in knowing where to go. And don't hesitate to ask for help.
Well, we appreciate the help that you have given us today. Dr. Suzanne Haney, thank you for joining us again.
Thank you guys so much.
To read the report Evaluating Young Children with Fractures for Child Abuse, go to our website at aap.org/podcast.
Coming up, we'll look at a new study that examines invalid vaccine doses.
Joanna, how well do you know your children's pediatrician?
Very well. He's probably listening now. Dr. Berger, I am so lucky to be going to your private practice and to know so many of the physicians there whom I really love. Thank you for taking such great care of my 3 kids. I wouldn't go anywhere else with them.
That is a lovely message for your pediatrician, Joanna. Since we moved to Wilmington, my kids always saw my partners, who were also good friends of mine, and yet we still got reminder calls for their health maintenance exams from our own front desk. No one ever thought to just walk down the hall and tap me on the shoulder, but that was probably wise. Everyone got their vaccines on time.
So far, we've been on schedule for all of our kids. Zelda just had her 1-year shots and her last COVID shot in early January. And the 1-year visit is a tough one with the extra pokes you get for lead and hemoglobin, but she did really well, and I'm really proud of her. But it's not at all uncommon for children in the U.S. to miss vaccines or to get them too early or too late, potentially making them less effective. In turn, this leaves kids more vulnerable to preventable infections.
That's a missed opportunity with potentially tragic consequences. To tell us more, we have Alexandria Albers and Sophia Newcomer on the show. They're the authors on a new study in pediatrics, Invalid Vaccine Doses Among Children Ages 0 to 35 Months, 2011 to 2020.
Alexandria is a former biology teacher and now PhD candidate in the PhD in Public Health program at the University of Montana. And Sophia holds a PhD and MPH in epidemiology and is an associate professor at the University of Montana School of Public Health and Community Health Sciences. Alexandria and Dr. Newcomer, welcome to the show.
Thanks for having us.
Yes, thank you so much.
I'm intrigued by the title of this article, Alexandria. Can you tell us what we mean when we say a vaccine is invalid?
Yes, absolutely. So I'll start with a little bit of background just to kind of describe how we get to that term, invalid. So in the U.S., we have the Advisory Committee on Immunization Practices, which probably we all refer to as the ACIP. And they're the ones who really give these recommendations that children should receive multiple vaccines in their first few years of life, is the realm of which we're working in the first couple years. But they also provide recommendations for a minimum age that a vaccine can be given. For the rotavirus vaccine, there's a maximum age that each dose should be given. And then for series that require multiple doses, there's also an amount of time that should be allotted between each of those vaccine doses. And when vaccinations are given outside of these guidelines, that's when we call them invalid. And I say we, but this is a term used widely. ACIP refers to them as invalid. And doses that are given in this time frame are recommended to be repeated by ACIP. So that's where that invalid piece comes in and how we kind of think about dealing with them.
And Sophia, how is it the ACIP determines the right ages and intervals to give vaccines to kids?
Yeah, so we were really fortunate that one of our co-authors, Matthew Daly, who's a pediatrician at Kaiser Permanente, Colorado, he was a recent member of the ACIP. And so from working with him and also just following the ACIP, since all of their deliberations are public, we can get a really good sense about how they make these recommendations that are on the childhood immunization schedule. And so in terms of the optimal timing of vaccinations, that's based off evidence from clinical trials and other available scientific evidence about the vaccines. Most of the recommendations that we see are based on the optimum timing for kids to have the best immune responses to these vaccines. So kids need to be a certain age to have a good immune response. And then with these vaccinations that require multiple doses, we need to allow for some spacing between the vaccinations to help boost that immune response so that they have durable immunity for a long time. With regard to the rotavirus vaccine, that vaccine is a little bit different. These recommendations regarding the maximum age is based mainly off safety concerns. An earlier rotavirus vaccine that is no longer on the market was associated with a small increased risk of intussusception. And so the trials of the new vaccine focused on looking at safety in younger children, and the safety in older children, we just don't have enough information. So I believe that's why the ACIP has these maximum age recommendations for the rotavirus vaccine.
I know we have databases to track vaccine administration when it occurs on time, but Alexandria, where did you find data on these invalid vaccine doses?
Yeah, so vaccines tend to go into kind of any record keeping, whether they're invalid or not. But where we pulled these data from is from the National Immunization Survey Child, or what we refer to as just NIS Child. And this might not be familiar to everyone, but the way that we nationally surveil vaccination, and again, I'm specifically talking about childhood vaccination from birth to right before they turn 3 years old, is done by an annual phone survey of parents. And so this is the National Immunization Survey, and the CDC conducts and sponsors this survey. And parents will get a phone call and they'll ask to answer some questions, not only about their child's vaccination, but also collect different variables about their own, like household demographics, for example. And then parents are asked for permission if they can contact the child's immunization providers to verify these vaccine records. And then, thankfully, all of this is publicly available data for most of it. There are some things they withhold for confidentiality, but we're able to use publicly available NIS child data to answer these questions, which record the age that each vaccine was given.
And what did your study find about how often this was occurring, Alexandria?
Yeah, so we looked across a time period from survey years 2011 up through 2020. At the time that this whole project started, that was pretty close to when the last year of data was available. But we found that over this whole study period, that 15% of U.S. children did receive at least one invalid vaccine dose. Now, on a positive note, we did find that from 2011 to 2020, that did decrease in the amount of children that received an invalid vaccine dose.
And Were there certain vaccines where it was harder for families to stay on track?
Yes. So we had the top vaccine series, the top percentage of children who received an invalid dose of that series was attributable to rotavirus, specifically the 3-dose rotavirus series. So that was about 4.4% of U.S. children had received an invalid rotavirus dose. But behind it, at about 3.3% of U.S. children received an invalid 3-dose Hib vaccination. And then there were a couple others below, but those are our main two.
Alexandria, do we know how many of the children in this study went on to get caught up on vaccines so that they would be effective?
Yes, 45% of children actually who had an invalid vaccine dose then went on to get what we kind of are calling like extra doses that were valid that then make up a completed series. And I also should note, we did take out the rotavirus vaccination when it was specifically a maximum age violation, because of course the recommendation for those kids is not to get a repeat dose. We don't want them to keep getting doses after a maximum age.
Sophia, can you suggest ways practicing pediatricians can use this data to help them reduce how often children receive invalid vaccine doses?
Sure. I think, first of all, what I hope that our research does is just help alert pediatricians that invalid doses can occur. And we also want people to know that there are tools available that can help, because the immunization schedule can be quite complex in the first 2 years of life. So in 2012, clinical decision support for immunizations was developed and rolled out. This is a technology that can help pediatricians know which vaccines to recommend at the right ages. And if your electronic health record system doesn't already include clinical decision support, that can be something that pediatricians can look into. Luckily, all states and many large jurisdictions maintain immunization information systems, or IIS, and these are centralized databases that help clinicians know what children's complete immunization histories are at the point of care. And these IIS systems also incorporate clinical decision support for immunizations. So even if you don't have that set up in your practice, it's very likely that you can rely on your state or jurisdictional IIS for those guidelines.
So when it comes to the IIS, we should all say II. Speaking of that, this has been a... I'm good for a dad joke every now and then. So this has been a truly eye-opening study. Do you have any last takeaways for our listeners? Alexandria, let's start with you.
So a big takeaway for me from the study actually came about really thinking about how these invalid doses apply to vaccine preventable diseases. And, I'm being trained in public health, so this is a really important concept, right? Even though there is a risk of increased vaccine preventable disease vulnerability if they are getting doses outside of these age guidelines, not all of the issues we were seeing, of course, would contribute to a higher risk of disease. So there are other things happening, such as this maximum age for rotavirus that isn't necessarily increased risk of disease, but has other types of things that we need to be thinking about as far as just lack of safety data. But then because we have kids completing doses with extra doses, we have them then completing series. There's also a lot of kids that aren't ending up at risk and are ending up protected. So it really depends on what we always talk about as like the typology of the invalid dose. And it's just a really important consideration, I think, when thinking about these types of issues in vaccination delivery.
And Sophia, any last thoughts for us?
Sure. One thing that we know from quality improvement is that we don't know we're getting better unless we measure it. And invalid doses are not always tracked. So what this study contributes is that we did look at many years of data on U.S. children, and we were able to track over time. And as Alexandria mentioned earlier in this conversation, we did see decreases, which is positive. We think it might be due to better technology, like clinical decision support, that helps providers make the right recommendations at the right time. And what I would contribute in terms of moving forward is that we need to continue to track invalid doses to make sure that we're continuing to improve in terms of giving routine and timely vaccinations to help protect young children.
Well, this is such a wonderful study. Alexandria Albers and Dr. Sophia Newcomer, thanks for joining us today.
Thank you for having us. It was great.
Thanks a bunch.
To read the study, Invalid Vaccine Doses Among Children Ages 0 to 35 Months, 2011 to 2020, go to aap.org/podcast. This week, instead of our Say Ah, we're sharing a special giving voice. This one involves a pediatrician and her longtime friend.
Once high school friends and now both child health professionals, Dr. Wendy Hassan and Jamie Poslawski sat down together at the 2024 AAP Advocacy Conference to discuss the epidemic of gun violence and what drives their advocacy work. This clip starts with Dr. Hassan.
I think the story that people aren't talking about is actually the individual gun deaths. And we know that the vast majority of gun deaths actually occur in people's homes with the guns that are in their homes.
Yes.
And something that I don't just worry about, but that I see is suicide deaths amongst adolescents. And everyone's talking about this lack of resiliency amongst adolescents and how there's this mental health crisis and how social media is contributing to that, right? But we're seeing the results of that with an increase in suicide attempts.
Yeah.
And that can end in multiple ways. And adolescents, we know, are impulsive, right? They don't have good executive functioning. They don't make good choices. Even the best kids will have lapses in judgment because that's their job. And if they're having an emotional moment and they have easy access to a gun, they're going to make a lethal decision that they maybe wouldn't have made 10 minutes later, right? I mean, just a couple of months ago, a teenage boy and his first girlfriend, who'd been with for, a year and went to his first school dances with and all these things, and they broke up. And he went and got his father's gun out of the safe that was not locked. And he went out into the yard, into the garden, and he shot himself. And his mother watched it happen from the kitchen window.
Oh my God.
And I mean, like, you can't even begin to absorb the amount of grief that you see when you're part of that.
Well, and then
that
the girlfriend
story,
and the people
right?
who survive it. And that's the thing that sticks with me, because the more common these events are, and all the ones that we don't see on TV or read in the news that happen every day.
Every day.
And the trauma and loss of that boy in the beginning of his life, his mother witnessing that, his father's guilt, I'm sure, at having this gun not secured, the girlfriend who broke up with him and never meant for that to be a lethal decision. It's just the layers of it are a lot. And even our young kids having to go through active shooter drills, even if, God willing, they never have to have an experience where they're victims of gun violence, they know in their core that someone could come into their school with a gun. I mean, this is just a different way to live.
It's a different way to live. It's an absolutely different way to live. And I think that parents, like when your kids are young, you think about all of the obvious ways that you protect them, right? You're like, okay, well, I have my kid's a year old, so I don't have any marbles out, right? Because your kid will choke on that. And
I'm sure your house, like my house, because our work in pediatrics is like very extra safe, all the things.
Very extra safe,
right?
Yeah. My son is almost 6. My husband's like, when are you going to stop cutting his grapes? And I was like,
this is a joke.
Like, I mean, yeah, forever. But the philosophy of cutting his grapes is, in my mind, the same as locking up your firearm, which is that, right? I'm like, it takes 3 seconds for me to cut up his grapes, and maybe he can eat a whole grape responsibly, but he's a pretty wiggly kid with hyperactiveness, and I can't afford to be wrong.
Right.
And I think that that is the message that I want parents to have, which is that every parent says the same thing to me when they wind up in the ICU. They say, I never imagined I would have been here. Like, this is not my child. My child doesn't make decisions like this. I didn't know my child was depressed. I didn't know that my child would ever even think about doing this. They all say that to me. And yet I see teenager after teenager in the ICU. And so it's clear that parents, even though you think you have a really close relationship with your child, there are parts of your adolescent that you don't know and you don't understand. And so what I would say to parents is, like, locking up your gun is the same as cutting my son's grapes. Like, you cannot afford to be wrong. Like, the price is too high to believe that your child wouldn't do that. And it's just such a simple way to protect not just your teenager, but your friends' teenagers. You know, we've seen those stories too, of friends that are together, and just, like, I'm just gonna say it again, like, you can't afford to be wrong. Cut your kid's grapes.
Right.
Put him in a helmet.
Yeah.
Like, lock up your gun.
Thank you, Wendy Hassan and Jamie Poslawski, for giving us your voice.
This story was recorded in partnership with StoryCorps, a national nonprofit whose mission is to illuminate the humanity and possibility in us all, one story at a time. Learn more about StoryCorps Studios at www.storycorps.org/studios.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss environmental issues in global health.
We'll talk to the author of a new policy statement, Dr. Philip Landrigan. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinki. Thanks for listening.